pencil, take out your paper, take out something that you would use to, something that you can keep a lot of this information in and, write things down. The next thing is please mute your mics. Please, as much as possible, we would love no interruptions when our speaker is speaking. So, or when the speakers are speaking. So please mute your mics as much as possible. If you have questions, raise your hand, or we will take the questions after as our guest speaker has, finished, his time. All right, so you can raise your hands, you can drop your questions in the chat box while you wait to be called on, or you could raise your hands that when we are taking questions. And I also encourage you to drop messages in the chat box as much as you can. We love to see that. So yes, we love to see that. First off, so the first person we'll be starting with for today, who will be speaking, is our dear support group member. Her name is Mission. Mission is a support group member on the Endo Survival Support Group. We would love to have her now share her story with us for a few minutes. Mission, are you here? I did see you. The floor is yours.
All right, Rolanda, thank you very much. Good afternoon. And thank you, everyone. Thank you, Miss Olivia, and every member here. My name is Mission. I don't know, can everybody hear me?
Yes, we can. We can hear you.
Thank you. All right, so just to jump into the story. My period started at 11. The first few years were good. There was no issues, no pain, just normal. I can't remember when the pain started, but I know it started small and progressed slowly over time. I just remember asking and saying at different points to different people, why is there pain now? Why am I feeling this discomfort? Okay, so it started as a discomfort. It was initially smooth, nothing at all. I wouldn't even know, like I really wouldn't know when it's coming. Then I started getting those discomforts. So I was like, okay, I don't used to have this discomfort. Why am I having this now? And they're like, oh, what do you feel? I was like, oh, I just feel this, maybe tingling here and there. And it's normal. There are people that feel worse. And that was how it was. So it kept progressing like that. It became worse, worse, worse every year. But I was still managing. I then had to start using painkillers. I still talk because I remember going to the nurse. I think I had malaria or something one day. And I was like, okay, it's just a quick one. My period, I don't understand why it's painful now. And I have to use pain meds. And she asked me again, okay, I've gotten questions, but like the intensity. I described it and she was like, oh, well, people have it often. I think I was maybe 17 there about then or 18. I think, yeah, I think 18. Yeah, I was 18 then. So progressively like that, it kept getting worse. But in 2023, at that time, it was really bad, like real, real pain, basically overdosing on pain meds. I then noticed a bulge just above my belly button. I checked online and it was like, okay, I just the first thing you see when you see that kind of those hernia. So I was like, okay, I never had a surgery before. I didn't have a big belly button. And so why and this bulge is not even on the belly button itself. At least at that time it was just above it, so showing and pointing out a bit. So you could just feel that's unusual when you touch that side. So I just went on like that, but I got worried because it started getting bigger. I wasn't keeping the timeline, but all these things happened as slow as I can say. I then I went to the hospital and they said I should go for scan. So I went for scan. They said that I should see a gynae. So they said there was a cyst in my ovaries, and that's one of my ovaries. And there was this, I can't, I've forgotten the medical term now, but just, yeah, very on black or something said. Anyways, I did that, and the doctor just dismissed me and said, well, he asked me some questions. I was like, oh, this was not so big, and just take, was it prednisone? Yeah, prednisolone and diclofenac. That was my first intro self to diclofenac. I was taking Selvin, even though Selvin was not working so much, but Selvin was my stable pain meds at the time. But then he prescribed diclofenac and prednisolone, and so I took that whole course, but nothing changed. I still the nodes was still there, and he was like, if it's progressed, I should come. But I didn't go back to that particular doctor. I traveled to Abuja, and I think there was this time it was I'm sorry, I didn't explain that it got difficult when during my period I started having difficulties breathing. But again, like I said, it was that note that made me more worried. I didn't put the two together that okay, there could be something, there could be a link. I then went to another hospital through my HMO. That was even Reliant or even their HMO. So I went to their clinic in Abuja. I called first online consultation. Then she was like, well, she can't say it for that yet, but it's sounding like endometriosis, but I should visit their physical office and have like a diagnosis, a proper diagnosis. So I went there, then they sent me for scans again. They asked questions obviously, they sent for scans. I came back and they're like, oh, wow, you have, well, what we see is really looking like endometriosis. But for us to know for sure, we'd have to have an exploratory laparotomy. But they can't have it there, so they referred me. I didn't go to their own referral. I started asking people around for gynaes and all. I wanted to go to National Hospital. Then National Hospital was like, so it was hard getting like an immediate um first immediate, like, public hospital, you have to like, so I now got a consultant who has a personal clinic, a gynae consultant over there. So I went to his personal clinic and then I still did test again. I'm going to mention that these three tests are done, the one at home, the two in Abuja. They also indicated I had ascites in my abdomen, and but my livers were okay, so they were like, it's giving endometriosis, but they said MEX syndrome. Some said MEX syndrome, but one other doctor said, well, that's like the broad term, but I would say it's more of endometriosis to me. So I went to this other doctor, and that was where I had the surgery to exploratory laparotomy. They there were like I think four things. Yeah, the node in my belly button or just above my belly button. It was blood, so basically in the endometrial whatever was bleeding in my belly, so that was because of ascites. Then they removed I think some I saw two things in my left ovary, yeah, my left ovary. So they took the specimen for histology, and then histology confirmed that, oh, it was endometrial. Because the doctor who said he was really like trying to feel that he wanted to be sure, he wanted to go first. He wanted the histology report to come first before he says for sure that okay, this is it. Because he said with ovarian issues, they can be anything, and most symptoms look alike. So that was where after the surgery, I went on Zoladex for 3 months. Then I had surgery in December 2023. So Zoladex January, February, March. Then I started having symptoms again. By the way, my breathing never really got better. So, but after the surgery, I got a bit of relief, maybe because my belly was fine. I don't know. But I started having like this real difficulties breathing. Every little thing gets me tired. So I was like, let me go back. I've been going for checkup anyways, but it was all belly, my belly, my belly. So I went back for this checkup, and they were like, okay, go for a chest X-ray, and that was this. And I saw that truthfully, my right lungs had even collapsed. So they explained that I'm breathing fine because it happened over time. If it happened spontaneously, it would have been an emergency case. So then I had to have I've forgotten the name now. They decided it to it took me like about 3 weeks in the hospital for all of that. Then I did a periodosis, and I was placed on Liprolide again for 6 months, which I am currently on, and that's been my journey so far. So it's been a journey of uncertainty and would I say information gap and pain as well. But thankfully, I reached out to endo survivors in 2024 and got in touch with Miss Olivia, and it has been like a very good support system with the sisters. I hear other people, so I now know that my problems are not. I'm not alone in my problems. But till now, I still don't know anybody. Like I've not met anybody outside of the group that has this thing. So it was before coming. It was like, okay, is this a lone thing? There was just this isolation I was feeling. But as I come, I hear other people's issues, different treatment methods has been encouraging and spirit lifting. So thank you very much. And that's my end of story.
Wow, mission. That was that was something. That was a lot. We really, really want to appreciate you for sharing your story. You are not alone. There are so many of us that are in the same situation or similar. We appreciate you for telling us from, when it began to when you had a surgery and then you had, a bulge and, ascites and all that. Sometimes I just feel like, oh my gosh, that is a lot to go through, but we are so thankful that you are able to share your story with us. It means so much to us. It's a source of inspiration and encouragement that you are still here and want to encourage you that you're not alone. Sisters, everybody, well wishers, please share in the comments, encourage mission. This is a lot for even just one person to go through. So please encourage her, give her, thumbs up, give her all the nice emojis, share them, encourage her, tell her you are loved, you are well, all that. Thank you. I see them, I see the emojis, I see the comments. That is beautiful. Thank you, everybody. Before we go on, thank you, Mission. We appreciate you. Before we go on, quickly, you know that today we actually have a special guest. And previously, I didn't mention his name because I wanted to introduce him very specially. However, I will just mention his name right now, and the introduction will come after our next um, speaker shares her story. So today we have in our midst, we have somebody so so special, so high up, so qualified. Like I don't even know how else to put it. His name is Dr. Abdul Hakim Olajide Akintobi. He came really early as like 30 minutes before, like so punctual. He was here to make sure that everything was set, and I really, really love that. His name is Dr. Abdul Hakim Akintobi. Please, everybody, welcome him in the comments. He's our guest speaker for today, and he'll be taking us through what it takes, what works for you in managing endometriosis. Please give him a round of applause. Give him all the love in the comments. Share the emojis. Dr. Akintobi, you are highly welcome. We appreciate you for coming on time, for being here, for taking out some time in your Saturday to spend with us. We are very, very grateful. We also want to appreciate, once again, want to appreciate the Society of Gynecology and Obstetrics of Nigeria, the members of Society of Gynecology and Obstetrics in Nigeria. You are welcome. We also want to welcome the Association of Gynecological Endoscopy Surgeons of Nigeria. They are also here. Our doctors are here in the house. We are happy to have you. Thank you so much. Thank you so much for being here. We are grateful. Thank you for taking out time in your weekend to spend with us. We know that everybody's schedules is like just busy and all that. We are grateful. We are grateful for our guest speaker being here. We are grateful for members of SOGON and AGES being here. Thank you so very much. And now would like to call on Mrs. Munira to share her story with us. She's also a support group member. Mrs. Munira, you have the floor.
Hi, good afternoon, everyone.
Good
Can you hear me?
afternoon.
Okay,
Yeah,
hi, everyone. Hi, hello to the whole Endo family. Welcome. Hi, doctor. I have to give a special greeting to my doctor, Dr. Hakeem Toby. So this is Munira. I joined the group not too long ago. It was just about 8 months ago. And I've had a fantastic time being here. I've read a lot, I've seen a lot, I've spoken to Olivia. So a lot has happened. I'm here to share a little bit of my story on this journey. I turned 41 this year in October. And I think my endo story started way back from when I started my period as well. That's around age 11. I've always had period pains, but yes, period pains, you just call it period pains, and that's how it's been going. A lot of pains. I remember every time of the month, I'm buying my Nurofen as a backup plan. I must be on Nurofen. But I didn't make anything out of that. I was young and that was it. So I think I started getting worried about it when I was about 18 because at some point the pain got a little bit more intense. And still, there wasn't any diagnosis. If I go to the hospital, it will be, oh, normal. When you have period pains, when you give birth, it would stop, you know? It's always been like that. So I was just doing well with my Nurofen all the time to suppress the pain. I got married at an early age. I got married at 21. So, with God's blessing, I didn't have an issue with conceiving and all. So I had my babies. I have 3 kids. I was opportune to have that. So I think what helped and kept suppressing my pain is after the delivery, I will always go on a family planning method. So using that, I wouldn't have periods. So my periods would either come in spotting form or I don't have periods completely. So when there are no periods, there are no pain. So I kept going that way till another time I was trying for my son, like after when I was like 28, and I had a lot of pain. So I saw a doctor here in Abuja that said, oh, probably you would have what is called endometriosis. So it was just by the way, I didn't know what it was. I didn't read much on it. It was just by the way. And then, okay, what do I do now? He goes, no, nothing. Once you get pregnant, it will go away. And that's it. I was lucky I got pregnant again. I had my son. So after him, I had a family planning um, for years. So it was back to back. So the pain didn't really give me a lot of issues because I wasn't bleeding. I only get pain when I bleed. Then 3 years ago, um, I decided to try again for another baby. I took out my family planning, and that was where the problem started. I was bleeding a lot. So at first, I was still giving it, could it be it's coming from the family planning patch that I took out? Okay, I was giving it time, but it was taking too long. 6 months, I was still bleeding that much, bleeding to the way that pads cannot even hold my bleed. I had to start having the menstrual pants. I was buying the menstrual pants every time I'm on my period. And to last year, it was something else. I was having injections and I was in the hospital every single month, still with no proper diagnosis. I still did not hear the whole endometriosis thing. I just keep remembering from the doctor ever mentioning it at age 18. So from last year, I started making more researches because I tried few IVFs, it didn't work. I tried all of that. So um, I saw a doctor that said she thinks that it's endometriosis. I should go and have a scan, a CT scan. I had an MRI that confirmed that. Then, oh, before the MRI, I was referred to this Dr. Akin. He's our guest speaker for today. So I went to see him. I haven't met him before. Heard he's a consultant from National Hospital. We spoke. Tried. He didn't really do much of convincing because he just said, "Go and make your research about me," and because I wanted him to convince me about everything. He said, first, the pain that you're feeling is too much. My pain was already intense. I was having had drugs that weren't easing the pain, and it was really bad. So after I met Dr. Akintobi, he told me to go and do an MRI. I had an MRI, I got it to him. He said he was crazy. But when I went to his hospital, one thing that I got confident about is how confident he was in explaining. His consultation took me about 3 hours. I've never sat with a doctor that long. He sits with his patients. He explained every single word to me, let me have every question I had, explained everything to me. Unfortunately, mine has gotten to a stage that I needed to have a surgery. So I decided to do the surgery in his clinic. I'm just 4 weeks post-op at the moment. Today is Saturday, yeah, just 4 weeks ago. So had the endometriosis surgery. Mine was a lot has happened. My organs were stuck to each other. I had too much of the chocolate cyst. I was bleeding internally. So it was quite a lot. We were in the theater for 8 hours, and Dr. Akintobi stood there and did as much as he could. So, what I have to say so far, I just got my period yesterday after the surgery. I still have pains. I still have pains, but I would say again, because of the extent of mine, because I haven't been diagnosed early enough. Pains I've been having since 12. I'm 41 now. So you can tell how long it's been with so much. I've had the Luprodex experience before my surgery. I've had a dose of it. I didn't like the side effects because it came with a lot of hot flashes and it was very, very uncomfortable. I had an uncomfortable month. So I haven't gone on that route again. I've refused to go on that route, even though doctors advise that we should. I still haven't gone on that route at the moment. So that's where I am. I encourage everybody in this group and outside that we should get tested early, and awareness is very important. If people get to know about it, they get to tackle it earlier. So I hope my little story would help somebody and still encourage somebody to be able to take the bold step in making the right decision on what it is on this. And may God heal every one of us. Thank you very much, dear sisters, and this beautiful support group. Thank you very much, Dr. Akintobi. And that's it. Thank you.
Wow, thank you so much, Mrs. Munira. Thank you so much for sharing your story. I really connected with that when you said, like, if you had been diagnosed earlier, it wouldn't have been so bad. Maybe recovery would have been better. Maybe the pain would have been much less by now. Everybody, please send her emojis, send her hugs. Thank you so much for sharing. These are things, some of the things you said I could relate to, taking Luprodex at some point for 6 months, including what Mission said, having, lung collapses. I can also relate to that a lot, and, ascites. So I relate to, like, everything here. I'm so happy for you sharing your story. And just had a surgery, and I hope that you are, healing fine. We hope for you for a smooth recovery, and we pray that you'll be better in the coming months. Thank you so much for sharing. Thank you,
Thank you
Mission.
too.
Thank you, Mrs. Munira. We are grateful for you. Thank you so much. And thank you also because suddenly you have introduced us to Dr. Akintobi. So thank you so much. Thank you so much. We will take some time to acknowledge our founder's husband. Sometimes when you're going through things like this, you always need people around you. You need support, and this man has just been wonderful. He has been brilliant. His name is Mr. Chukwemeka Nwakudu. He is a member of the board of trustees and the husband of our dear founder, Mrs. Olivia Nwakudu. Please appreciate him in the comments. Appreciate Mrs. Olivia Nwakudu. Appreciate our um, speakers that have shared their story. Appreciate them so much. Thank you, thank you, thank you for all you do. We are grateful. I see the hand emojis. Oh my gosh, they're coming on. Thank you so much, everybody. We appreciate everyone. We appreciate you, sir. Thank you. Thank you very, very much. So we are gonna take a little pause right now. We're gonna do just a little question. Um, I know some of us here are not in this on the support group yet, or we're not there, but there's one question I would like to ask just briefly, and I want it to be in the comments. I want you to unmute your mic just for like a minute. And this question goes like this. It says, what would you love to see more of in the support group? So for people that have been on the support group, you've seen how it runs, you've seen how it goes. Is there something on your mind, that You're like, okay, well, if we have this, we'll make it better. So what do you want to see? What do you want to see more of on the support group? Let's have it in the chats. Okay, someone says, Beautiful says, I'm new here. This is my first time of joining the community. Welcome, Beautiful. We are glad to have you. I see another comment from it says, okay, it says all shades of amazing you are, sir. What would we have done without you and God, Mr. Unwakudu? Wow, that is Dami appreciating, Mrs. Dami appreciating Mr. Unwakudu. Thank you very much. So the question is, what would you love to see more of on the support group? Or if you haven't joined the support group, like what are your expectations? Just let us know in the comments. Thank you very much. You can unmute your mics just for a minute if you want to speak on that. What would you love to see more of on the support group, or what are your expectations about your support group? What do you want? What do you want to get out of it?
Hi, Rolanda.
Hello,
Hi.
Patricia. Yes.
Okay, so I wanted to speak because I don't think I can type exactly what I want to say. On the
Mhm.
support group, I would love to see more volunteers, more people joining in activity, more people speaking up. It's kind of very quiet. Few people are doing so much, and it's really a lot for us to achieve. Imagine that for all the women we have here, if we were able to have been reached at a very early age, I know that we wouldn't go through a lot of this pain. So, what we are trying to do is reach women at very young ages so that we help them, we educate them, and help them to get help very, very early. So, we need more volunteers. We need people to speak up. We need people to be available. That's what I would love to see. We have a lot of people. We can do so much, and we need to use our social media platforms too to reach people. WhatsApp, LinkedIn, Facebook, Instagram, even if it is Snapchat, any platform is enough just to spread the word so that we can have less women going through this pain.
You're absolutely right. Thank you very much, Trish, for that. That is true. We encourage maximum participation in our support group. That is why we are there. We're not there to be silent, and just observe. We're there to also participate. And that's something we encourage when we have people that reach out to us that want to join the support group. Because if you don't participate, then you're not as involved, and you're not as you know, we are not participating in what we are supposed to be doing on the support group. So please, if you're on the support group and you happen to be here, please ensure that you are, responding well to our messages and all that, and then that you are also participating and contributing to the well-being of the community. Thank you very much, Patricia, for that. Right about now, we would like to introduce our guest speaker in the person of Dr. Abdul Hakeem Olajide Akintobi. I would like to read out a bio of him. So today, again, to remind you, we are discussing finding what works for you in managing endometriosis. Dr. Abdul Hakeem Olajide Akintobi is a chief consultant gynecologist at the National Hospital Abuja and medical director of ASFA Specialist Hospital, Dawaki, Abuja, which is a center for excellence for minimal access surgery and a referral center for endometriosis and many gynecological conditions. Dr. Akintobi he graduated from the prestigious University of Ilorin in January 2000 and completed his residency training in obstetrics and gynecology at the University of Ilorin Teaching Hospital. Dr. Akintobi is trained by the West African College of Surgeons 2009, World Laparoscopic Hospital in Delhi, India, IRCAD in Strasbourg, France, ELEXEA in Alexandria, Egypt, the Royal College of Obstetrics and Gynecology in 2019, and the European Society of Gynecological Endoscopy, ESGE, obtaining various degrees, certifications, memberships, fellowships, and diplomas in the field of obstetrics, gynecology, and endoscopy. He pioneered operative gynecological endoscopy in many Nigerian hospitals. He's a senior lecturer at Nile University, Abuja, and he is a renowned trainer in the field of minimal access surgery in Nigeria. Dr. Akintobi is happily married to a beautiful radiologist with children. Please welcome him in the comments. Welcome him with emojis. Thank you, Dr. Akintobi, for being here. We are grateful. Thank you for your time. The floor is yours, sir.
Thank you very much, Rolanda, for that kind introduction. Thank you very much. Thank you for having me. The Endo Survivors International Foundation, I'm really grateful for the invite, for being part of this project of support for endometriosis patients in our community. I also want to appreciate Olivia for specially sending the invite. We have listened to two survivors, Mission and Munira, who happen to be my personal patients. And through her, I got this recognition. We appreciate the fact that you're able to come out and share your story. This is the way to go. If people don't know what happens to you, they won't be able to relate, and they will not be able to know where to seek for help and get the appropriate care when needed. So I want to appreciate you all the beautiful endo survivors that are all here. I call you champions. As far as I'm concerned, if you have lived with endometriosis and you are still going, you are a champion. That is what I call you. Thank you very much. So having said that, let me try and share my screen. I've been asked to speak about endometriosis. Can you see my screen?
Yes, sir, I can.
And yes. Everybody can hear me. Okay, so I've been given the responsibility to talk on endometriosis, and the topic is exploring treatment paths and finding what works for you managing endometriosis. Endometriosis is a big topic, we all know. Even if I'm giving 1 hour, it will be difficult to talk about endometriosis. But within the limited time I have, I've tried to summarize as much as possible, and I'm going to try and break it down to simple language. I do know, I realize that our audience are from different backgrounds, so we should be able to speak the language that everybody can relate with. So, the introduction has made, just a minute. No, okay, so I need to unshare and then share again because the slide is not rolling. Just a minute. Technology. So let me take it out of slideshow first. Yeah. Okay, so we're good to go. The introduction has been made, so I'm going to give my talk under this outline. I will talk to us briefly about what normal physiology of menstruation means. Every woman at age of maturity starts menstruating, and how does that come about normally? And then we have to define what endometriosis means and look at the possible causes of endometriosis. And what are the things that you see that could tell you that you have endometriosis? And we have posed a question to ourselves here: is there a cure for endometriosis? And what are the options available for endometriosis patients? And is it possible to have endometriosis in the chest? We've all listened to Mission, and we'll look into that briefly as well. And at the end, we are going to look at endometriosis care in Nigeria as it is today and what we want it to be in the future. The normal process of menstruation, we do know that when women achieve puberty and they have grown to the stage where they are ready for reproduction, the first sign we see is that they start menstruating. And what happens within the body before menses is revealed is an interplay that involves several organs within the body, right from the brain that coordinates the whole activity. So which means the brain also needs to be mature to be able to initiate as well as coordinate the menstrual cycles. So there are certain chemicals that the brain will release, and these chemicals act on the ovaries. So when they act on the ovary will respond to these chemicals, and they will also produce their own chemicals called estrogen and progesterone. Estrogen now acts on the womb, especially the lining of the womb, which is the uterus, and it helps the lining of the womb to grow, okay, in preparation for pregnancy. Progesterone adds to maturation of that growth, hoping that pregnancy will happen so that the fertilized ovum can have a very conducive place to implant and grow. But if in the process that the woman is not able to get pregnant in that month, the lining of the womb is going to shed. And that shedding is what we see as menses or period. So like we mentioned it, like we say in the medical parlance, a disappointed womb shed tears. That's what menses means. The womb has prepared for pregnancy, but because pregnancy did not happen, the womb is disappointed at the end of the day, and it decides to cry. The cycle continues every month, okay? So the next month, the same thing is repeated all over again. So this is what we expect normally. What is endometriosis? Now, endometriosis is when cells similar to the cells from the lining of the womb start growing elsewhere. And because the womb is an organ located in the pelvis, most of the problems are usually located in the pelvis. And as you can see from the picture that I called out here from the Royal College of Obs and Gynae website, here you have the womb centrally located in the pelvis. In front of the womb, you can see the bladder. At the back of the womb, you can see the rectum. To the side, you have the fallopian tube and the ovaries. Endometriosis can start growing in any of these locations. You can see abnormal growth here. These are all illustrations. Abnormal growth here, encroaching into the bladder wall already. These can also go and encroach into the rectum. There are times that this also grows as deep into the vaginal wall. Other locations that this can be found are the belly button. You had the story of mission. In fact, some develops endometriosis on scar tissue when you've had abdominal surgery before, like fibroid surgery or cesarean section, and then suddenly you start developing a bump that becomes painful every month on the scar. And then you can have this growth anywhere, unfortunately, anywhere in the body. Okay? So, by way of statistics, we need to all realize that we are not alone in this battle. It is a global phenomenon. All over the world, women suffer from endometriosis. If you look at an average population, for every 100 women, between 2 and 10 of them will have endometriosis. In fact, it has been quoted that as much as 50% of women who are struggling to get pregnant have background endometriosis. All over the world, it's estimated that more than 190 million women and adolescent girls are suffering from endometriosis while in their reproductive life. Even when women enter menopause, some still continue to suffer from endometriosis. So endometriosis is a chronic condition. Locally, we do have some statistics that we also quote. In Ibadan, women who have gynecological condition that's had to undergo laparoscopy, almost half of them were found to have features suggestive of endometriosis. And in Kechebelu in Ine, we also, in 2015, while evaluating women with infertility, almost 5% of them have endometriosis. What causes endometriosis? This is a common question we are faced with in the consulting room. A woman wants to know why. Why me? Why should I have endometriosis? Am I responsible for the problem? And if you look at our environments where we have so many computers who are not medical, there are so many explanations that will have been given to women why they are in pain. So by the time they are coming to the consulting room, they have so much in their head. Is it your fault that you have endometriosis? As a matter of fact, even as scientists, we do not know for sure why women develop endometriosis. But there have been a series of theories, okay? Scientists have promulgated that could be the reason for that. Could it be that when women are menstruating, some of these cells escape through the fallopian tube into the peritoneal cavity and then they start growing there? Okay? But we found out that even in women without uterus, they still develop endometriosis. Why? So several theories have been promulgated. So I won't go into details of this because this is purely academic. And we find a situation where even locations far away from the pelvis, at least let's even assume that the uterus is in the pelvis, the neighbors can easily become contaminated. But what happens in the chest? Why is it that patients can also have endometriosis in the brain? So several theories have been promulgated to explain that. So we do not know for sure why women have endometriosis. What are the things that you see in your body that will let you know that you could possibly have endometriosis? Ironically, some women have endometriosis without any symptoms. They are fine. They don't have any issues. But for one reason or the other, probably we have to go in and do cesarean section. And then we see features of endometriosis inside. Or a patient have reason to do other gynecological surgery. And then we find endometriosis in them. And for some, if they don't have any intervention, they might not even know. But for those who will have symptoms, how does it manifest? Very painful periods tends to be a common denominator for endometriosis. Mark the word very painful, okay? It's not unusual to have some minimal cramps from periods, but when your pain from periods starts affecting your normal day-to-day activities, it's no longer a normal condition, and it has to be evaluated. And it's good to know that this group is there to provide awareness to our young women in school, but the parents also need to know, because when the children start complaining that they are in pain, they cannot go to school, they are chastised, some are called lazy and demonic or what have you, but it's not their fault. They actually need care. And this pain tends to be chronic over time, pelvic pain that becomes so chronic. Okay? The pattern can even change. Initially, it might be that it's only when you're in period that you're having it. And for some, it starts even going beyond the period time, and some are even perpetually in pain throughout their cycle. So endometriosis do come with a lot of symptoms that we cannot actually explain why. Some can start having issues, passing urine. I shared a picture showing how close the bladder is to the womb. So during period, you see them going to urinate frequently. And if it has invaded into the bladder wall, they can even start passing blood in their urine. The same thing with bowel. The bowel movements, some have diarrhea. Once their period comes, they are always in the toilets because the endometriosis have now started irritating the bowel or even invading the bowel muscles, and they can even start passing blood in their stool. Some find it even difficult to have intimacy with their partners because endometriosis has infiltrated the vaginal wall. And a few might also find it difficult to get pregnant. And it is during evaluation for infertility that we make diagnosis in these patients. So how do we make a diagnosis of endometriosis? When you come to the consulting room,
check I'm going to hear the behind wall. Because by the time I came, they told me no.
Can we move to speak mics, please?
Have you wrong or this place?
Please, can we mute our mics? Okay.
So, when you come to the consulting room, we listen to you. Endometriosis patients have so much story to tell, and it is our duty to listen to you. And most of the time, it is in the consulting room that the endometriosis patients actually have the opportunity to tell their story the way they want to be heard. Because when they talk to anybody, it's usually they shut them down or they just wish it away that this is nothing serious. So when you come to the consulting room, we take our time to listen to your story. And this helps to guide us in arriving at the diagnosis, and at the same time, how to formulate your treatment starts from listening to you at the beginning. We're going to perform physical examination on you. Of course, this is a disease that tends to affect the pelvic organs. So, which means internal examination might become necessary as part of evaluation. And this we usually do in the presence of a chaperone. But if you have objection to this, we'll respect your choice. There are other ways we can always assess you. We are also going to run some imaging tests on you, ultrasound scan, and the recommended scan for evaluation is usually what we call the transvaginal scan. It is an internal scan that gives us very good resolution, and because of the proximity of where our probe will be towards the pelvic organ, we can do very good assessment of the pelvic organ. And I must mention here that actually endometriosis scan is quite different from regular ultrasound scan. And you also need to have that evaluation done by someone who has been well trained in the act of scanning for endometriosis. Because many patients will have had series of scans and they don't see nothing before coming to you. And when you now do the scan and tell them that this is there, they'll say, but I've done scan before. Why didn't they say it? You cannot blame the scanner. You know, the scan that you did was done generally at, how will I put it? Like a general scan. They are not specialized scans. So endometriosis patients actually need specialized ultrasound scan to make assessments. Following that, most of the information that we need, we do get from ultrasound. And the fact that we now have high resolution ultrasound around is actually the recommended first line test for making diagnosis of endometriosis nowadays. Other imaging that we do involve magnetic resonance imaging. This tends to give us more details as well. And then it affords us the opportunity to also look at the extent of invasion of organs in any part of the abdomen. It also helps the surgeon in case your situation requires intervention to do proper planning ahead of time for your surgery. Laparoscopy is another tool that we do employ, and this is the camera test into your tummy to assess the abdominal cavity. This can be used for the purpose of diagnosis as well as treatments. So I will elaborate a little bit more on that later. Now, the poser. Is there a cure for endometriosis? Unfortunately, as we speak today, there's no known cure for endometriosis. Possibly, if we wake up tomorrow, scientists could have found a cure and we'll all be happy if that happens. We do know there are a lot of research going on in the care of endometriosis. So hopefully one day we'll get there. So as of today, we do not have a cure for endometriosis. So endometriosis is a chronic condition, which means once you have it, you are likely to live with it for a long time. So how do we control the impact of the disease on your life, as well as ensuring that this does not pull you down? But so we do know that we can manage endometriosis as it is a chronic condition. And what are the options that we have for treatments? The treatment for endometriosis is usually individualized, and it is based on several factors. Treatment that we're going to give patient A might not be appropriate for patient B. and the same treatment might not be appropriate for patient C. So assessments of the patient to determine the type and severity of the symptoms, how much of the disease that the patient have, as well as the location will help to make appropriate plan for such patients. Are you willing to get pregnant immediately? These are also considerations that we need to look into. Some have completed their family size, so they have no plan to get pregnant again. How we are going to manage such patients is different from someone who is actively looking for pregnancy. The adolescent girl in secondary school is not married, is also not planning to get pregnant, but she has future plan to be pregnant. So all this must be put into context while we are formulating treatment plans for our patients. Patient willingness to use contraception is also put into consideration, because part of the management plans could involve medication that are actually contraceptive devices. And personal preferences for treatments also matters. We did hear from Munira that a response to a particular drug was not palatable. So that must always be factored into consideration when you want to give treatments.
Okay.
Can we move to our mic, please? Sorry. So we do not have guarantee on what will give you the best results. Unfortunately, no guarantee on what will give the best results. But we do know that when we offer you care, we can help to alleviate the extent of the injury that this disease might have caused internally, as well as improving quality of life. Treatment options. We can give you medicines. Pain, we do know that pain is a very significant part of endometriosis, which actually affects quality of life, self-esteem, social life, and even ability to go and earn a living can be significantly affected as a result of pain. So pain medications can be given to actually alleviate this pain and make the period to be bearable. Other form of medications that we give are hormonals. My first slide tried to tell us what happens generally with menses. So if we can actually tinker with your period and try to manipulate it, we can relieve your symptoms by giving you contraceptive medication. And what these drugs will do, essentially, is actually either to make your period to cease or to defer your period, make you bleed less, and at the same time, control the extent of the disease that you have. So if there's no period, there won't be pain. So this is the objective of using this medication. They can come in form of pills, injections, patches, or even coils that we insert into the womb to help minimize the suffering of the patients. There are more drugs that are being introduced into the market every day to help alleviate the suffering of patients. And in some situations, surgery might become quite indicated. And why do we do surgery? Surgery helps to free organs that have been stuck together When organs that are neighbors that naturally should move freely without any issue start getting stuck, this also contributes to pain that patients experience. Even these organs function cannot be optimal when they are involved in a lot of scar tissue. We've seen women coming with bowel obstruction because endometriosis has eaten so deep into their bowel. And in such a situation, you might need to go and excise that part of the bowel that is involved in the disease so that the bowel can regain freedom. We've seen situations where endometriosis will encroach on the ureters. Ureters are the pipes that conduct urine from the kidneys to the bladder for us to be able to pass out as urine. And when there's invasion of ureter by constriction or invasion, the ureters will not be able to drain the urine freely. And this starts creating what we call back pressure effect on the kidney. And there's possibility that if we don't relieve those obstructions, the kidney involved can actually suffer significant irreversible damage. And you know what that means when patients start having kidney failures as well, in addition to the ongoing process. So surgery becomes indicated when women have such situation for us to be able to free those organs from the effect of the disease. And we also use the opportunity of the surgery to remove every active disease that is present during the procedure. Now, all these modalities can be given in isolation or in combination to achieve maximum effect. So, patient can be on hormonals and painkillers. Patient can have surgery and then follow up with hormonals as well. Are there other non-medical options that we see our patients patronize? Yes. People do a lot of nutritional management. They want to regulate what they take. They go on supplements and what have you. Chinese medicine, electrotherapy, acupuncture, physiotherapy, exercise, psychology, all these have been tried by patients with endometriosis. We do not know the potential benefits of all these options and the harms that come with them. So from the medical point of view, we hardly recommend them, but patients will have actually had all this. Most of our patients will have gone through all this without any significant improvement in their symptoms. Surgery. What type of surgery is recommended? Laparoscopy is the treatment of choice for minimal access surgery. And superior to that is robotic. Robotic also make use of the same principle of laparoscopy, but this makes it much easier for the surgeon to operate without undergoing unnecessary stress. But where all these are not available, open surgery might be the only available option to manage such patients. What is laparoscopy? Laparoscopy is a minimally invasive surgical procedure that allows a surgeon to examine and operate on the organs inside the abdomen and pelvis without making a large incision. It uses camera system with magnification. So the resolution of the images that we get is actually better than our naked eyes. So that's what makes laparoscopy to be more superior to open surgery when it comes to treatment of endometriosis. So apology, I should have given a warning before showing this. I'm sure some people don't like images like this. And I've tried to limit it to these 4 pictures. What do we see when we do laparoscopy? The first 2 images you see at the top, this is what we call peritoneal implants. They look quite superficial when we go in by laparoscopy, and we see this. This tells us that there's endometriosis that is ongoing in this location. Ironically, you cannot determine the extent of the disease by just looking at this. When we try to excise all this lesion, at times the depth of invasion is quite very significant. So this is what we see. In more severe cases, we get to see pictures like this. Ovaries on the left with significant blood within it, the uterus and all the organs plastered together. Similarly on this side. And this is what we call frozen pelvis. And there's no way you will have this kind of organs stuck together and you will not be in severe agony. That is what we see when we go in for laparoscopic surgery. And it is our duty to ensure that we free all these organs, remove all the active disease, as well as the chocolate cyst in the ovaries. Is it possible to have endometriosis in the chest? Yes. Endometriosis can happen anywhere. You can have it in the chest, eyes. We've seen patients in the literature that shed tears during their period because they have endometriosis in their eyes. Endometriosis can happen in the brain, okay, where patients start having neurological manifestation during period. You see patients having convulsion and other forms of medical issues. Having their
MRI, right?
Can also have endometriosis encroaching into the nerves. So when you have
no. Pastor, this pastor is essentially for
Dr. Adekunle, you are disturbing.
Hello, Dr. Kintobi, please.
Okay, can you hear me now? Can you hear me now?
Yes, we can hear you now.
Okay. So nerves can also be involved. When you see patient complaining that anytime I have pain, I have this shooting pain that, radiates through my thighs, to my leg, to my buttocks, that tells us that whatever the lesion is, has started encroaching on certain nerves. And it is only when you go and remove those lesions that the nerves can give sigh of relief. When you have endometriosis in the chest, patients can start manifesting with at times during their period, some cough, chest pain, and because of the chronic nature of it, they are able to cope, just like we had from mission over time. And it's only when you do evaluation that you see that a lot of blood has accumulated in their chest, compromising the lungs to be able to function well. And when you have to offer treatment for this kind of patients, you need a collaboration with chest surgeon to be able to manage this patient appropriately. What about fertility concern? It's good to know that most women can conceive and deliver naturally. At least you've heard from Munira, even though her symptoms started while she was very young, she was still able to go ahead and get pregnant and deliver her children. So it's possible that women can actually conceive with endometriosis. But some, unfortunately, will have difficulty getting pregnant because of the impact of endometriosis on the natural process that involves conception. And the desire for pregnancy is a significant consideration when we are offering treatments. And some of these patients could eventually be helped by offering them IVF. which is in vitro fertilization. Unfortunately, the disease at times could have been so bad that the ovarian reserve of the women has been so compromised that even when you want to offer them IVF, we could barely generate any eggs from their ovaries to be able to fertilize and assist with conception. So in such situation, surrogacy and adoption might now become the option of choice for such patients. Talking about endometriosis care generally, what does it entail? The care of endometriosis is actually not a one-man job. It requires many specialists because a lot is happening with the patients suffering from endometriosis. And there's all the concept that we call MDT, which is the multidisciplinary team. And this is being encouraged globally for the care of special situations like this, especially endometriosis, where you must have relevant specialists who have been trained in the care of endometriosis as it might relate to their primary specialty. Gynecologists, a general gynecologist still needs to be exposed to the training that will make them specialists in the care of endometriosis. Bowel surgeon, not all bowel surgeons too, they also need to also understand what endometriosis is all about. And if they have minimal access surgery skill, it makes it better for the patient. Bladder surgeon, chest surgeons, all these surgeons with minimal access surgery skills will give better outcome when they are involved in the care of the patients. Even nurses, needs to be trained in the care of endometriosis. Pain specialists, even when we have done the surgery, the pain might still not go away. You've had Munir, and that is the reality. So you might still need pain specialists to help us to regulate the kind of drugs that patient can have to help them to manage with their pain. You cannot, of course, take away the fact that there's a lot of psychological components to living with endometriosis. And the list is not exhaustive. So as the patient presents, we might expand this list to ensure that we have the appropriate team on board to manage them. So what is the state of endometriosis care in Nigeria? As we speak, even when some of us were in the medical school, we used to believe that endometriosis, we don't have any issue with endometriosis in this part of the world. That is a white man disease, but unfortunately, we now know that endometriosis is not just a white man disease, it's a global phenomenon. Here in the country, we are picking up more diagnoses and we are releasing more statistics to prove that endometriosis is here and is living with us. Awareness generally is very poor. We shouldn't beat ourselves too hard. Even in the developed world, it takes time to arrive at diagnosis of patients with endometriosis. But the more we can do to educate the populace, even among healthcare practitioners, the better it will be for our patients. And then we'll be able to pick up endometriosis early enough and manage patients appropriately. So nowadays, we are having an increasing number of centers with high resolution ultrasound scan, and the skill set to also do transvaginal ultrasound is increasing. So we are picking up more cases, we are making more diagnoses. Laparoscopy is also becoming more readily available. Unfortunately, there are few centers with capacity to do endometriosis surgery, especially by laparoscopy. This is our situation as at today. Where do we want to be in the future? There's need for more advocacy. And I must say again that Endo Survival International Foundation has taken the bull by the horn. I do know that there are probably also more foundation out there trying to also do their bit to raise awareness. The more we have, the better for us. We need to take this advocacy to a higher level. Apart from educating the populace, even our policymakers need enlightenment. Because if the policymakers are also not carried along, no matter how we do, I mean, how much effort we have put into this fight, when this patient eventually come forward for care, how do they access the care? The manpower needs to be there. The facility needs to be there. Training of the manpower that will care for this patient. Medication needs to be available. So policymakers also needs to be carried along in our advocacy. Education, yeah. Let's take our, advocacy to the secondary school level, just like you've been doing. But when we involve policymakers like the Ministry of Education, for example, there's nothing wrong in introducing endometriosis as part of topic that will be taught in secondary school. So which means that the young girl that's about to start menstruating is already aware of possible issues. Those that have been menstruating, that have started having issues, can quickly know that, oh, this is what is wrong with me. Even the boy child should know about endometriosis so that when their sister cannot get up from bed every month, they can easily raise awareness that something is wrong with their sisters. There's need for us to train more specialists. And of course, you are all aware that there's brain drain ongoing and it's not abating. Okay, so more of our good hands are leaving the shore of the country. Some of us went out and we came back, but that ratio is not equal. We have more that we are losing out than those that are returning. So there's need for us to train more specialists. I've showed you what the MDT looks like, okay, in all specialties, and provide them with the tools that they need to work with. We need to have established dedicated endometriosis centers. It will be practically impossible for all health institutions or facilities to take up the treatment of endometriosis because of what goes into it. So we need to actually prioritize, look at our resources, train manpower regionally, and then we can start moving to state level to ensure that we have dedicated endometriosis centers and establish good referral system that can help our patient to get care early enough when needed. Robotics needs to come into the country. As a minimal access surgeon who have been doing this for years, I can tell you that endometriosis surgery is not an easy surgery to do. And the only way we can be assisted and to make it easier for us to also perform this surgery is if we have tools like robotics. So you see the reason why I kept talking about policy, the policy makers to help us in the drive. So I'm going to conclude by saying that living with endometriosis can be a very stressful condition with emotional, physical, social, and economic consequences to sufferers. Individuals with endometriosis should not be left alone to deal with this problem, as it can be quite debilitating. They need support financially, socially, and morally. So we need to come together to help patients who are suffering from endometriosis. And I say to all endo warriors, do not despair. It's available. Thank you very much for your patience and attention. I'm sure whatever I've not been able to cover, I will be able to take care of them in the question and answer section. Thank you very much for having me.
Thank you so much, Dr. Akintobi. This was lovely. You literally covered like the entire thing. I'm so happy. As you were speaking, I was like, okay, yeah, I got this thing. I'm like, and I was looking at the comments and people were commenting. I'm like, wow. Thank you so much, sir. This has been wonderful and lovely. We appreciate it. Please, everybody, appreciate him. I already see the emojis and emoticons. Please comment, say, doc, thank you, doctor. Thank you, Dr. Akintobi. Thank you for giving us. This is like a lecture, honestly. It feels like I'm in medical school right now. Thank you so much for that lecture. That was brilliant. That was it wasn't too long, it wasn't too short, and it just went straight to the point. What we needed to hear, basically. Thank you very much, sir. Before we go on, I would quickly like to acknowledge someone in our midst, someone that has done endometriosis research. I know a lot of people here are doing endometriosis research, but there's one person in particular we want to say hello to. His name is Professor Joseph Ikeche Belu. I'm sorry if I murdered the name. Professor of Obstetrics and Gynecology and former acting Vice Chancellor of Nnamdi Azikiwe University, Oka. Hello, sir. Hello, Professor. We thank you. We are grateful for your work in endometriosis research. And he also happens to be on a paper that was quoted by Dr. Akintobi. So this is one of the reasons why we wanted to acknowledge him for his work and for his efforts in driving endometriosis research in Nigeria. Thank you very much, sir, Professor Ikeche Belu. Thank you, sir. Also, thank you once again to Dr. Akintobi. We are grateful for your help. Let me look at the comments and see what we have. I saw that we have some comments from Beautiful. I remember that I saw a comment from Beautiful, and she says that she would love to reach out more and spread awareness across zones. She says she seems to be in Port Harcourt. She doesn't think that we have reached there yet. So, wow, Beautiful. That's actually nice. I would like you to reach out to us. Um, reach out to us so that we can, discuss further about that. I believe that there is a link already dropped, or you can reach out to us on our social media platforms. I'm also going to drop that in the chat very soon. Let me see. I believe that there's also another comment. Beautiful again was saying something about her own experience. Said I was recently diagnosed of this condition and it has affected me in ways I cannot explain. My life has not been the same. Every month there's the fear of what periods hold for me. I was rushed to the emergency unit last Saturday that 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 my period showed up. I stood all day while on drip and injections and so much excruciating pain. It has not been easy. I'm so sorry, beautiful. We identify with your pain, we identify with what you're going through, and we want you to know that you are not alone. Okay, there are so many of us here on the call with the exact same thing. Um, Okay, and then somebody also asked, Rukayat says, is it true that endometriosis can be found in fetuses? That is a very, very, very specific question. So I don't know if you can help us with that.
Yeah, thank you, Rolanda. Before I answer the question, let me also appreciate the presence of Professor Joseph Ikechebelu. Actually, he is my mentor, and we have done so much work together in trying to train minimum access surgeon in this part of the world. So if there's anything happening with regards to minimum access surgery in Nigeria, one singular person that we have to give credits to is Professor Joseph Ikechebelu. We are happy to that he joined us in this program, and he was our foundation president for AGIS, Association of Gynecological Endoscopic Surgeons of Nigeria. So yeah, very interesting question that was asked about can we find endometriosis in the fetus? So now the issue we should look at is this. We do know that endometriosis many a times, in fact, over the years, confirmation was restricted to histology, which means that you take tissue to the lab and the lab looks at it and then they say, oh, what they are seeing is looks like endometrium in this, the lining of the womb in this location you have taken the biopsy for. Okay, so if you need to do biopsy for whatever reason, and then you find something that looks like endometrium, then you probably say endometriosis exists there. However, will a fetus manifest with features of endometriosis when we know that they have not started menstruating? It will be difficult to say so. And when I was talking about causes of endometriosis, there were so many theories. I decided not to go into the details of those theories. Okay. In fact, the location where the endometrium grows from, okay, they are from different parts of the body before they now get to where they are eventually. So those locations, in fetus, if you do histology, you can actually find them there. Yes, literature could have reported it, but will they suffer like us who are adults, manifesting with symptoms and what have you? Is very unlikely. And I think this paper too also actually need to go and look into it and see what happened then, But histology, if you do histology on somebody and then you find something that is endometrium outside the lining of the womb, of course, that's the diagnosis. It's endometriosis. But if the person suffering from it, might not be so. So that's how I answer it. And I don't think you should be afraid of our unborn child having endometriosis right from inside the womb. Thank you.
All right, sir. Thank you very much, sir. Patricia, I see that your hand is up. Please, can you ask your question now?
Okay, thank you very much, Rolanda. Thank you, Dr. Hakeem. God bless you so much for this wonderful session. While you were speaking, you mentioned a case that was peculiar to mine. While my doctor was in the process of the laparoscopy, he discovered that I had a frozen pelvis. So, but he went ahead with the surgery, and when we were out and the back and forth, one professor said that he wasn't supposed to have gone ahead with that surgery. He should have explored the different treatment method because I had complications. So, and I had to go back for another surgery, and there were a lot of serious complications that period. I want to ask, what would he have done when he found that? Should he have stopped that surgery he was doing midway? What other options would he have explored? Because I had ovarian cysts too, very large ones. I think there were two, or I think one was very big on my right ovary then. And the pain was intense. It was 247 every day. Like I was in constant pain, so I was on constant medication, the diclofenac suppository, Felvin at a point, injections, drip, all manner of things just to manage it. The pain was just too unbearable. So, and he had said that he needed to do that surgery. But that other doctor said he shouldn't have continued when he noticed that I had that frozen pelvis. Thank you for that pictures anyway. So I have a picture of what my system looked like as at that time. So what could he had done? And was he right to have gone further, or he should have stopped? How could he have managed with the cysts that I had too? Thank you very much.
The question is clear. I understand you perfectly. Rolanda, do you want me to take the question as they come, or you want us to batch them?
I think it's okay to take the questions as they come.
Okay, thank you. Oluwaseto Adeboye, I'm sorry to hear about your story. Endometriosis surgery, even in the hands of the best surgeon, is a risky surgery to do. So I must lay that background. That your surgery was complicated could not have been intentional. The disease makes your surgery to be a difficult one. So having laid that background, I do know that many a times surgeons do get to see surprises when they get in there during the surgery. And the reason for this, is multifaceted. At times, it is as a result of pressure from the patient, operate me. At times, of course, from our own side, if we didn't take our time to do proper evaluation, I mentioned ultrasound, MRI, many people will wonder, why do you want to do MRI? Have you not done scan? Did you not see what the problem is? All these things are very essential component of preparation. It helps to prepare the surgeons ahead of the time. That when I go in, these are the things I'm likely to see. Okay? So these are background of issues that we do to help us to avoid surprises when we get into surgery. Now, could you have had surgery or something else? You were in pain. It was obvious that you needed help. The extent of the disease showed that you probably require surgical intervention as well. So surgery was good to have it done. Why this complication happened, I'm sure after the surgery, the surgeon will have sat you down to also explain a lot of things that could make this possible. Even like I mentioned, in the best hands, complications do happen. I do have complications as well. But before surgery, I explain to my patient very well. So patients are actually aware that this surgery that we're going in for, there's a possibility that we could run into your bowel. There's a possibility that we could damage something in your bladder. There's a possibility if the ureter is involved, we could injure it, okay? Even vessels can be injured. So these are all information that I give my patient before going in, so that when the complication actually happens, they are aware ahead of time that yes, this could happen. And then when complication happens, like I mentioned, complication happening is not the problem, but are we able to also deal with the complication? So our ability to also deal with the complication also matters. And the fact that you are here talking to me today means that your doctor did a wonderful job looking for help, ensuring that you get all you needed to get to make you get out of the theater safe, though with complication, not because it could be intentional, but because your surgery was a difficult one. I hope I was able to answer your question.
Yes, sir. I understand you from what you said. I mean, my doctor never did any of this for me. He allowed us, because my brother is a doctor, so he kind of placed the whole responsibility of every other, like what you do for your patients. You sit down, have consultations with the patient, they have to run series of tests and everything. He should have noticed that he didn't have, the only thing he had with me was the test that I had done here in Abuja before going to Calabar, because I did it in Calabar where my brother is. He just took that, looked at, he didn't do anything of his own. He did not have an intensive discussion with me about what to expect. If he had done what he did, I'm sure he would have noticed that I had that. And then he would have told me, oh, these are the things that, can happen if we do this. We must do this. I would know that, okay, this is what can go wrong, or this is what is to be expected. This is what I have. He never did any of that. He just told me because the cyst is very big, he has to go in for the surgery. I'm very sad to say this. Unfortunately, that doctor was more concerned about his own part of what he was going to get from it, not about giving me care. I am very, very sad to say that. Apologies to all the doctors around it. It's a very bad thing. I know I've met good doctors. My brother is a doctor too, so I know that we have very good doctors that are very intentional about their care. But he didn't give me that. And then after the procedure, though the people in the room, the other medical practitioners said when they saw that, they had told him, and he insisted on going further. I don't know what to say about that because I have no idea what should have been done. That's why I'm asking. But after the procedure, I was told that he was advised to put me on just drip for 72 hours and all because he punctured my intestine. He did not. In fact, he asked me to start taking fluids. I should take PAP. My mom came. I had a laparoscopy on Saturday. Sunday, he discharged me. My mom came with PAP, with water, everything I should take. And I took those things. And in the hospital, when I threw up, my brother noticed one greenish bulbous substance, which he brought to his attention. And he ignored it and downplayed it. And I went home and I had to be rushed back to the hospital the next day because I had a distended abdomen. They had to rush, put NG tube in me, start doing it, and I had to go under total anesthesia again in within how many days? It wasn't up to 3 days because they had to rush to do a repair surgery, which I couldn't even come out of all of that. So I did not have the opportunity. Even after all, when he came to speak to me, he didn't speak to me like a doctor. He just sat down, was listing all the things that were wrong with me. He didn't offer me any help, any way of managing this thing myself. Just that, So it's a pain I have been carrying. I have dealt with it for a while. When I spoke with Olivia, she's been helping me. I've met other doctors too. I've been able to manage it so far. So, but I wanted to know if there is a chance that he could have done something different, just in case, because I'm using my story to speak to other people. If there's more information, while I talk to people, I can tell them, okay, in my case, this was what happened, but you can do this and do that. It was a very peculiar case because I had cysts, to ovarian cysts, alongside the endometriosis, which was very, very inflamed, and it was causing me so much problem. So it wasn't just, the endometriosis that we're going to treat, other things. So I understand all of. He did not give me that, not how I'm hearing it now. In fact, I did not have good medical care and attention, which is very sad for me to say.
So sorry to hear your story. We do all have different experiences with our caregivers. No doubt about it. I cannot downplay your experience, and I cannot say what your opinion about your caregiver is wrong or not. You were the victim, and then you have the right to express yourself as you have done. And I think moving forward, it's good to know that you are healing. It's good to know that the foundation has come to your aid, and it's good to know that you're sharing this as well. And I think what we should take home from here to all of us, for example, let me just tell you one story now, because now you related this very well that your brother was a doctor. So it's impossible that the conclusion for surgery happened between your brother and the doctor. That happens a lot. And as patients, I believe most of us are adults, especially except for the adolescents, who will need their parents to give consent. For us as adults, moving forward, we need to actually seek time to sit with our doctor and have conversation before any surgery. Okay? That conversation helps a lot. And like you have mentioned, this conversation was lacking in your care. So if your surgery had gone without any issues, we wouldn't have been here talking about it. But when there are issues is when we now know that, oh, we did not have all this conversation. Okay? So those conversations matters a lot. Patients call me on the phone, they want to know cost of surgery, they want to know the day when they want to come and do surgery. I tell them right away, I don't know what is wrong with you. I need to see you. But many a times they will feel like, oh, it's because you want to collect consultation fee. It goes beyond that. So that conversation is very important. Even if you are not physically present, this is digital age. You can do Zoom consultation with your doctor. Have a conversation, have a list of questions set for your doctor. Even after the initial consultation, you can still come back. It is at the point when you have now been satisfied that you now go to the next level. So I think that should be a take-home message for all of us moving forward. Once again, sorry about your experience, and I do wish that you heal well and get over this with time. Thank you.
Thank you, doctor.
Thank you very much, Dr. Akintobi. Thank you, Patricia, for your question. For everyone else, Patricia actually happens to be our coordinator for our support group in Northern Nigeria, and she's based in Abuja. We thank her for her selfless work. She has been doing a lot. Thank you, Patricia, and thank you for your question. I'm so sorry that you had to go through that. The next person we want to take for questions is Oluwaseto. Is Oluwaseto here? I saw your hand raised. Please, can you unmute your mic and ask your question?
Thank you very much, Rolanda. Good afternoon, Dr. Akintobi. Thank you for the presentation. I really learned a lot. My question is on adenomyosis. I've been told I have both adenomyosis and endometriosis, and I'm also trying to conceive. I also have, I think, frozen pelvis with additions and all. And I have an endometrioma on my right ovary that could not be removed during my last laparoscopy surgery because they said they could not find the ovary. So I've done several IVF cycles and FETs that with and without Lupron, and they all failed. So I've been trying to research and find out things on my own, and I read about adenomyomectomy. But I also read that there's a risk of uterine rupture and other complications, and that the surgery might not even work. So my question is there anything else to do? What would you advise? And does surgery work for the condition? Thank you very much.
Thank you. I actually mistaken you for the first speaker because I saw your hand up. I thought you were the first person to ask a question. So, yeah, thanks, Oluwaseto, for your question. Looking at your condition, this can actually predispose to all you are having, no doubt about it. Now, what we need to look at, even with your adenomyosis, there's nothing stopping you from getting pregnant with adenomyosis. It depends on how diffuse it is, and then the endometrium. If the endometrium is spared, okay, most of the time, pregnancy is possible with IVF. Now, for women with frozen pelvis, one common issue that militates against them having successful IVF is because there's something that they usually have that we call hydrosalpinx. Now, when the fallopian tube is blocked at the distal end, they tend to accumulate fluid within it. And when those fluids seeps back into the uterus, they are toxic to any embryo that is transferred. I don't know if you have it. So,
Sorry, sir. Yes, I've had several laparoscopy, and one of them was to remove a tube that had hydrosalpinx.
were they able
But
to
I had an hysteroscopy recently, and I was told the endometrium was severely affected and distorted, rather, and there's no ostium seen. I think that means the opening to the tube or something like that. So the right tube is still there, but I don't think it's visible either during the hysteroscopy or during the laparoscopy.
Yeah. So now, for the purpose of even the audience, when there's hydrosapiens like I'm mentioning, let me just conclude on that thought and then we'll move to the other one. When there's hydrosapiens like I mentioned, no matter the amount of IVF that you do, the tendency that it might not succeed is very high. Now, we do recommend, yes, go and remove it, clip it, and what have you. If you have frozen pelvis and the surgeon has difficulty accessing the side of your womb, they might not even be able to get to that location where the hydrosapiens is, and that makes it a minus. So this now requires intervention by somebody who can actually get to that level and deal with it. So that said, let's say you don't have hydrosapiens, yes. If your adenomyosis has actually infiltrated into your lining of the womb significantly, this is where there is trouble getting pregnant. Many a times, yes, we do give medications to help dry it as much as possible and help recovery. Adenomyotomy, which you mentioned, is also a surgery. And that surgery now involves that the womb will have to be cut open, and then all the area that have the adenomyosis is resected out and then reconstructed. Now, in a woman with frozen pelvis, that is also a difficult situation to do. So no matter what you want to do by surgery, ability to be able to clear those additions will have to be priority. Until that is done, you are not likely to be able to have any other successful surgery, be it the clipping of tube or be it even trying to remove the adenomyosis. So by and large, the extent of the adenomyosis will determine what you need to do. If it is not diffuse, the endometrial lining is not involved, and then with suppression for a couple of months, you could undergo IVF, but ensure that you do not have an hydrosapiens. Do not go for IVF with an hydrosapiens. Please, you just keep on wasting money doing IVF repeatedly. So that is the advice that I need to give in that regards. You might need to do more advanced imaging, to also help you to evaluate all these things that we have talked about. And I do hope that you'll be able to get help at the end of the day. So sorry about what you're going through, and it should be an ongoing conversation. We'll continue to see how we can assist the group moving forward. Thank you.
Thank you very much, sir.
Thank you very much, Dr. Akintobi, again. We're going to take about a 1 minute break or so from questions, and we want to we want to ask if Professor Ikeche Belu has anything to say. And we also want to acknowledge the presence of our matron of the support group, the mother of Mrs. Olivia Nwakudu. Her name is Dickiness Ngozi Amadi. Welcome, Ma. Thank you so much for being here. We are grateful for your presence and your support. She's the matron of our support group, Dickiness Ngozi Amadi. Thank you, Ma, for being here. Professor Ikeche Belu, please, do you have anything to say for today? Hello, sir. Professor Ikeche Belu. Okay, while we wait on him, we'll move on to the next question. I saw a question from Al Kotor, I believe. So if If you want to speak, I think that would be preferred. Alcothar, I don't know if that is your first name. I'm trying to search for your question. Let me see that. Okay, hold on. Okay, yes, she said, thank you, Dr. Akintobi. For a patient with severe endometriosis with frozen pelvis, apart from surgery, what other medical option is available for also preserving fertility? So that's her question. Patients with severe endometriosis with a frozen pelvis, apart from surgery, what other medical option is available that also preserves fertility? Dr. Akintobi, please could you assist us with answering the question? Thank you very
Okay.
much, sir.
Thank you, Kauthar, for your, is that from Kauthar? Yes. Thank you, Kauthar, for your question. So you said a patient has frozen pelvis and then she doesn't want surgery. Yeah, of course, if you don't want surgery, your options will be limited to medical treatments. Now, the preservation of fertility that you're talking about, is it that you're looking at future fertility or it is now that you seek fertility? Because your treatment would depend on that. If it is future fertility, yes, most of this medication that we give you to actually regulate your period, control your pain and what have you, they are reversible, okay? So once you're ready, those medications can be discontinued and then you can proceed with your fertility journey. However, if you intend to get pregnant now, then we're limited as to what we can give you, okay? Apart from pain meds, we'll just advise that you proceed with your fertility treatments, be it IVF, so that they can, you can even, if you decide that your fertility decision is even in the future, you can harvest your eggs now and freeze them. Because the thing about endometriosis also is that as time goes on, the quality of the eggs also continue to be getting poorer. So you can harvest your egg, freeze them, and when it is time for you to deal with the fertility issues, you just need to go to the bank and then make use of them, and then you can get pregnant. So it all depends. You want to get pregnant now or it's in the future? Those are the things that will determine what you are giving. But most medication that we give that controls your menstruation and your bleeding, they are reversible effects. It's not as if they permanently stop you from getting pregnant. No.
All right, sir. Thank you so much for that answer. In continuation of that, I would like to say that for next week, we'll be discussing endometriosis and infertility. So if you have more questions on that, please try to be here next week, same time, 2 p.m. For those that have more questions about endometriosis and infertility, your questions will be answered in more detail or be treated like specifically on Saturday next week. Thank you so.
Yeah, you are muted. We can't hear you again.
I'm sorry. I was saying that we do have another upcoming section, endometriosis and infertility, next week Saturday. So if you have specific questions on endometriosis and infertility, we'll be taking more of those questions in that section. So anybody sending questions about infertility now, we might have to hold those questions till next week. Thank you very much. Usman says, next week we're actually starting at 1 p.m. We are starting at 1 p.m. So please take note, next week, Saturday, for endometriosis and infertility, we're starting at 1 p.m. Someone says, how can we access endometriosis Endo Survivors Foundation? So I posted our social media links and our email in the chat box. Please look at that. Thank you very much. I believe that the next name is Udeme. Udeme, please unmute and ask your question. Thank you very much.
Okay, thank you very much. Good afternoon, doctor. So my question is this. I had endo surgery. I was diagnosed of endometriosis 1 year ago after so many years. So I had my surgery August of last year. So after that surgery, my cycle actually became very unstable. I complained to my doctor. Before I had the surgery, my cycle was just 28 days, between 28 and 30 days. I'm very sure of my cycle. But after the surgery, it became very unstable. Sometimes it would come after 16 days, sometimes 19, sometimes 24 or 26 days. So it continued like that. But exactly 1 year after that surgery, August of this year, I started bleeding. So I bleeded for straight 3 months. I bled, and so I was quite worried because I've never experienced that. Even with endometriosis, I never bled. So I went back to my doctor, and he suggested that it possibly is I have endometrial polyps. He recommended TVS, though I'm yet to go for it. But I don't know doctor, what do you think about it? What do you think would actually cause such bleeding 1 year after surgery? Do you think possibly there is a reoccurrence of the endometriosis, or do you think it is polyps that can make me to bleed like that? And note, the bleeding is chocolate. It's chocolate. That's exactly how it is. And then again, my abdomen is a bit swollen as it was before that surgery. So what do you think about that?
Yeah, thank you, Udeme, for your question. Yeah, so endometriosis, story from A to Z will always be different. So now with the narration, the quick question I wanted to ask after your surgery, were you given any medication as addition to help with your symptoms? As in, did you have to take injections or pills or what have you?
No, not at all. I was just given normal pain relief, that's all. I wasn't given any special kind of injection. Yeah.
Okay. Because I was just trying to troubleshoot why your period became irregular. Now, looking at what you are complaining about now, you said you are bleeding, you have been bleeding continuously. However, what comes out is chocolates in nature. Okay? When I have that in my patients, from my experience, okay, most chocolate discharge is coming from your tubes into your womb through the vagina and is revealing as that. And it can be very messy and uncomfortable for the patients. So in this situation, my first suspicion, before you mentioned the chocolate, I could have said, oh, yes, have you started developing fibroid? Have you started developing, if you have polyp, they could make you have erratic bleeding, but it hardly give you heavy bleeding. Have you started developing fibroid? Have you started developing adenomyosis? But continuous chocolatey discharge is usually like when you have a chocolate compartment in your pelvis that is now finding its way through the tube and is expressing itself through the vagina. That has been my experience with my patient with that. And when we take out the tubes, they go dry. So that's my thoughts. But you need to be evaluated to actually know why you are having this. And that will help to determine how to manage it.
Thank you so much, Dr. Akintobi. Again, we have just one more question. It says, I'm a bit confused with adenomyosis, ovarian cyst, adenomyoma, and endometriosis. Please, what are the differences? Adenomyosis, ovarian cyst, adenomyoma, and endometriosis. So I believe this person is a bit confused with all the terminologies. So please, could you enlighten us more about this? Thank you very much.
Well, at the beginning of the session, I said we shouldn't use too much medical terminology. This is what happens. It gets people confused. The medical terms should be the headache of the doctors. And what the patient wants to know is what is going on with me and how is it affecting me, So, but simply to just answer the question, ovarian cyst means that every woman has an ovary, okay? And even cyst formation is naturally physiologic for most women, okay? You form cysts, it ruptures, and another one forms. So most cysts that women have are physiologic without any problem. But occasionally, there are some cysts that will now persist, start growing bigger, they start causing the problem, and they can be from different causes, okay? Now, you make me to start mentioning medical terms again. We have dermoid cysts, chocolate cysts, and what have you. So there are different forms of cysts that can grow in the ovary. So that's aside, okay? Now, the womb is made up of outer covering, muscles, as well as the lining of the womb. So it's the lining of the womb that grows and sheds as menses. The muscles have their own function as well. This is the one that will expand to accommodate baby, okay? And it's the one that also contracts to expel the baby as delivery, okay? So there are times that you now also find, what's it called? The lining of the womb also growing into the muscles. So this is when we now start saying the woman has adenomyosis, okay? And that can consolidate further, form a mass, a district mass that is so, well circumscribed, we say this is adenomyoma. There are other things that can also grow inside the muscles, which the common one is fibroid, okay? So I'm sure everybody knows what fibroid is all about. But try not to get yourself entangled into what is this or that. Allow your doctor to discern what the issue is and how to deal with it.
Thank you much, sir, for that answer. I hope the person has more clarification on those terms and is satisfied with the answer. I'm grateful, sir, for you helping us to answer these questions, for taking us through, what endometriosis is, what are the notions that the likely theories, and how to go about the treatment options and managing it and all that. Thank you so much, sir. Thank you also to our speakers. We had Mission speak and sharing her story. We had Mrs. Munira also speak. Thank you so much for sharing, and also to our support group members that are on the call. Thank you as well. Thank you to the members of SOGON and AGES. Thank you very much for being here. Thank you for our well-wishers and supporters, our board of trustee members, and just everybody in general that was invited to this call. We are grateful for your time. We also want to appreciate once again, Professor Ikechi Belu for being here, and our other professors and academics in endometriosis and obstetrics and gynecology. At this time, I would like to call upon our dear founder for her remarks, Mrs. Olivia Umwakodu, to speak. Thank you.
Good afternoon.
Good afternoon.
Welcome. Okay. Good afternoon, everyone. Thank you so much for being here. Can you hear me, Rolanda?
Yes, we can hear you.
Okay. So thank you all for being here. Dr. Akintobi, thank you so much, sir, for being here. I really appreciate your presence. And I should also appreciate the presence of Professor Ikechi Belu. Thank you so much, sir, for being here with us, and all the members of SOGON, AGES, nurses, I saw some sonographers as well, and of course, the board of trustees of Endo Survivors, my mom, who's our matron in the support group. Thank you, Mom, for being here. All my beautiful sisters in the support group, thank you so much for your time. for being here. As Rolanda had explained, we have our support group meetings every year. This is our 6th year now, yeah. So we have it for 4 or 5 Saturdays every year in October. So this is our 6th year of doing this. So, and the group is growing and we are learning, we are getting better. And our programs at Endo Survivors are becoming, more integrated with the broader healthcare plan for patients, because we have doctors referring their patients to the support group. So thank you all for being here. So Dr. Akintobi, sir, thank you. On behalf of all of us in Endo Survivors and the support group, I'm presenting you this plaque. I hope you can see it. So I'm going to read it. This is an appreciation award presented to Dr. Abdul-Hakeem Olajide Akintobi, Chief Consultant Gynecologist at the National Hospital Abuja and Medical Director, ASFA Specialist Hospital Limited, Abuja. In appreciation of your intellectual contributions to our endometriosis support group meeting as a special guest, presented by Olivia Nwakudu, founder and executive director of Endo Survivors International Foundation, October 25th, 2025. Thank you very much, sir.
See your video. We didn't see your video. We only had your voice. Thank you very much.
We didn't see.
Thank you for having me. I'm grateful. This is a worthy cause. Having treated endometriosis patients over the years, I do feel your pain. This is not an easy journey for anyone to embark on. Whatever we can do to continue to alleviate the suffering of endometriosis patients in this part of the world, we will continue to do it, be it care for patients, be it also training manpower in the care for endometriosis. We'll continue to do our best. Professor Ikechebelu, it would be nice to have you say what's up. Thank you very much, Olivia, Rolanda, for having me. I'm grateful.
Okay. Thank you, sir. So I'll have this delivered to your office in Abuja, and we have a gift for you. It's just a token of our appreciation. On behalf of all the members of the support group, once again, we are presenting you this gift. It's a branded throw pillow, which you can put in your living room or wherever. It has your face and everything on it. So I'll have it sent to you in Abuja, courtesy all of us in the support group. Thank you, sir.
Thank you.
Okay. So thank you once again, everyone. We meet again next week. We are discussing endometriosis and infertility next week. So please, our special guest for next week is Dr. Eddie Osage, and he has requested that we start on time. So please, we're going to start at 1 p.m. so that we can do other things, so that he can have other engagements that he already scheduled. So please, I'm looking forward to having all of you. Thank you to all of those who joined us from Instagram, Facebook, Twitter, Threads, LinkedIn. I saw all your messages. Thank you. We tried to respond to as many as we could, and I hope you can bear with us if we haven't responded to you. But I'm sure you got the link in your email boxes. Then for those who want to join the support group, the link has been shared. I think Doni shared it and Rolanda also shared it. Please ensure that you fill out that link, read the code of conduct. We do have a code of conduct in the support group. So please read it, consent to it, and we'll get in touch with you very soon. Just be patient, okay? So thank you once again. And I want everyone to just unmute and appreciate Dr. Akintobi and all our guests. Before we go, just say thank you.
Thank you, doctor.
Thank you, Dr.
Thank you,
Akintobi.
We
doctor.
appreciate
All of
you,
our
sir.
guests.
Thank you,
Thank you, sir. Appreciate you, sir.
Thank
Thank you,
you,
sir.
Thank you.
Thank you, Rolanda.
Submission.
Thank you, sir.
Thank you.
Thank you, Dr. Akintobi.
You're welcome. You're welcome.
Thank you to our
Thank you,
moderator.
sir.
Thanks.
Okay. Thank you, everyone. So we're going to post the thank you cards to Dr. Akintobi on social media. So ensure you comment on it. Appreciate him. Let everybody know what a wonderful speaker and doctor and guest he is to have joined us. It's not easy to be here for a consultant over 2 hours just talking.
So we'll post that on social media. And so I'll send you the card as well. So please, everyone, ensure you appreciate him. And let's keep the conversation going on social media and, everywhere. So thank you once again. I love you all. And I look forward to seeing you again next week. Bye.
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 Bye.